which show the presence of lupus anticoagulant. What is the best course of action?
للكل السؤال.
هذا سؤال 25.
وارفرين.
تيم 1.
هنعمل اوفرلاب ما بين
كورس اوف تريتمنت، يعني التريتمنت احنا ماخذ عندها 2 دي في تي وجاء انذر فيردر دي في تي ولوبس انتي كواجولانت. duration of treatment لايف لونج excellent
good full mark.
طيب جادج دكتور احمد الروبي حيعلن النتائج.
طيب جروب رقم 3 90 درجة.
جروب 3 الجروب الثالث 90 degree.
الجروب الثاني 215 درجة.
الجروب الثاني 215 درجة.
الجروب الأول 225 درجة.
نهنئ الدكتور رامي حسنين، دكتور محمد التلباني، والدكتور مؤمن طبيل. يعني ما فيش فارق 10 درجات بس.
دكتور صابر السؤال الأخير كان زيادة
لا ما كان زيادة.
لا ما كان ولا سؤال.
ما كان فيش زيادة. احنا 25 سؤال تجاوبوا.
نبارك للفريق
الفائز وما شاء الله عليكم صراحة كان يعني 10. وهذا في ذكرى الدكتور أيمن أبو العوف رحمه الله تعالى، وشكرا لكم على حسن استماعكم. الآن طبعا في محاضرة للدكتور فادي صافي من في بعض الأسئلة تم إعطاء ربع الدرجة وتم إعطاء نص النتيجة، فبالتالي هذا اللي هو أثر في هذا. ما كان في إنه فل
دكتور علاء
والجادج بعدين إحنا we have two judge fair judge الدكتور أحمد الروبي والدكتور رامي أبو سلود and we cannot question this. صح ولا لا يا دكتور أحمد؟ Yes there is no bias. يلا بسم الله. طبعا الدكتور تفضل الدكتور أبو العلاء والدكتور علاء الدين المصري والدكتور أبو العلاء. دكتور أبو العلاء والدكتور علاء الدين المصري لتقديم الجوائز. مين كمان؟ دكتور حسن تفضل. دكتور حسن
مسموع الصوت.
دكتور محمد التلباني شيف ريزيدنت انترنال ميديسن ديبارتمنت. ناصر ميديكال كومبلكس. دكتور مؤمن طبيل من مستشفى الشفاء ريزيدنت من مستشفى الشفاء. طبعا دكتور رأفت لبد وصى قال اللي بيفوز في الجائزة بيعطيها للبروجرام دايركتور تاعه. فأنا بنقل بس ايش يعني ايش المسج. دكتور رامي حسنين طبيب واعد من المستشفى غزة الأوروبي، قام ترشيحه من قبل الدكتور رامي أبو سلود، وهو طبيب من أطباء الناجحين يعني صراحة والواعدين إن شاء الله. شكرا ويعطيكم ألف عافية. والآن الدكتور فادي صافي من أمريكا حيتكلم لنا عن الفنجل انفكشن.
في مشكلة في الصوت في التقديم.
هناك محاضرة لفارماكير.
تمام تفضل.
نبلش أحمد.
تفضل يا دكتور تفضل بل.
أوكي السلام عليكم جميعا. السلام عليكم. الدكتور فادي صافي معكم من أمريكا. أنا سعيد بوجودي بينكم وبحب أشكر الدكتور صابر على هذه الدعوة الكريمة. إن شاء الله إنه نقدر نكون موجودين بشكل شخصي في الأوقات القادمة. طبعا أنا مش متمكن من رؤية الحضور، لكن إن شاء الله إنه يكون الصوت واضح والفيديو واضح، وإذا في أي سؤال راح أتمكن من الإجابة عنه عن طريق الواتساب. اليوم إن شاء الله راح نتكلم عن الأمراض الفطرية التي تصيب الرئتين. إن شاء الله راح نتكلم عن أكثر من حالة. راح نتكلم عن النمط النسيجي والإشعاعي لهذه الحالات. راح نتكلم إن شاء الله عن كيفية التشخيص، ونتكلم عن طرق العلاج. طبعا هذه الحالات هي حالات إحنا موجودة عندنا في الولايات المتحدة، وإن شاء الله آخر سلايدين راح أتكلم عن الأمراض الفطرية اللي ممكن تصيب مناطق الشرق الأوسط. فبدون أي إطالة راح أتكلم إن شاء الله عن الحالة الأولى. الحالة الأولى هي عبارة عن مريضة 72-year-old. المريضة هاي she's immunocompromised. سبب الimmunocompromise هي she has a kidney transplant 1.5 years ago. She has also a history of hypertension and diabetes. The renal transplant because of diabetic nephropathy. She had history of cabbage and AV fistula. And medication-wise, she was on prednisone and mycophenolate and tacrolimus. So all of those are immunosuppressants. طبعا physical exam, patient she came with shortness of breath and cough. Physical exam temperature was normal. All of the other physical exam was normal. Laboratory finding, same thing, everything was unremarkable. And this is her chest X-ray and CT scan. I hope you can see that very clearly, but if you can see in the chest X-ray, you can see a lot of multinodular infiltrate, big nodules here in the right lower lobe. And then in the CT scan, you can see the fissure, the oblique fissure here. And you can see that there is nodules on the 3 large nodules on the right lower lobe. So our differential diagnosis at this point, it could be infection. It's either bacterial or fungal. We always think about that the patient, because she's immunocompromised, could be mycobacterium, or it could be primary pulmonary disease. It could be malignancy, of course, or it could be connective tissue disease. So what do we do in this case? We went ahead and we did some serology testing, and the serology testing came back with positive for cryptococcal antigen. So we did bronchoscopy with transbronchial biopsy, and we did CT guided biopsy. And as you can see, these pathology slides are from the CT guided biopsy, and you can see very well these structures. You can see these ovoid structures with a halo sign. They are empty from inside. Each structure is around 5 to 10 micron in size. We did some stain we call Musi-Carmen stain, and as you can see, the wall of that structure stain, and the diagnosis was Cryptococcus pneumonia, Cryptococcus neoformis. So we did the titers and we treat the patient with fluconazole 400 milligram for 1.5 years, and the patient improved significantly and those nodules disappeared. So Cryptococcus is present everywhere because, risk factors include immunosuppression and HIV. So you may be able to see that rarely, but it can happen. To move forward, I have 5 cases. So this is case number 2. Case number 2, we have 39-year-old male patient. He has history of HIV, and CD4 count was less than 50. He has history of IV drug use, and also he is a smoker. On exam, he was cachectic, and he has bilateral crackles on lung exam. The vital signs were normal. Lab data showed a sodium of 124, which is low, platelets high, and anemia and LDH high. When you see a high LDH in a HIV patient, you think about PCP pneumonia. When you see low sodium, you think also about PCP pneumonia, but also you think about Legionella pneumonia. This is his X-ray and CT scan. As you can see, it's very remarkable. You can see there's diffuse micronodules all over upper, middle, and lower lobes. This is what we call miliary pattern, or you can call it micronodules, diffuse, or tree in bud pattern. And the differential diagnosis of this is large. That can include bacterial pneumonia, such as H. influenza and Mycobacterium avium, fungal pneumonia, such as aspergillosis. It can be pneumocystis. It can be, we can see it in rheumatoid. We can see it in sarcoidosis. We can see it also in bronchiolitis and in cancer metastasis. So the other laboratory data came back positive for fungital, which is a enzyme for the or a protein for disseminated fungal infection. So we did bronchoscopy and transbronchial biopsy, and to our surprise, we saw this structure. If you see this structure compared to the previous structure, this is a very large foreign structure, which looks like we describe it as spherule. And if you look closely inside that spherule, you see these spores, we call it. So spores and spherule. This is 50 to 100 microgram in size. And the diagnosis for that, we call it coccidomycosis or valley fever. This is mostly only seen in the United States, in the western areas of the United States. And that's how it looked like. And the treatment for that will be a fluconazole as well, but high dose, and you do that as well for a year. And the patient after that improved. All these nodules that you saw before resolved. Case number 3, we have a 37-year-old male. He came with a left lung mass found incidentally. He was complaining of dry cough and weight loss. All of the other history is negative. He was non-smoker, and the exam was normal. And this patient, the interesting thing is that he came from Southeast Asia, so he's from Thailand. And if you see his CT scan, you can see that chest X-ray CT scan, you can see this mass in the left upper lobe. See this mass here? So this mass was interesting. We did fungal serology, and then we did bronchoscopy with transbronchial biopsies. So when we did the transbronchial biopsy, the pathologist told me that there's granulomatous inflammation. So when you see granulomatous inflammation, you see these granulomas with giant cells and histiocytes. And when you see this, you think about either TB, especially that is coming from Southeast Asia, or you think about fungus. But all the cultures came back negative, including fungal culture. So we didn't treat this patient, and he kept doing well. We repeat the CT scan, the mass was still the same. And then 3 months later, he came with these skin lesions, and he came with these, with the CT scan showing these small tumors or nodules in the CT scan of the brain. So we did biopsy of the skin lesion, and then the biopsy came back positive for these organisms. So if you can see this organism here, it is a thick wall organism. It's around between 5 to 10 micron, and it has a broad base budding, we call it. So there is like 2 structures, one of them budding from the other. When you see broad-based budding, then you think about blastomycosis. So that blastomycosis, this fungus can affect the lungs, the skin, and it can rarely go to the brain. So this patient, this is how the fungus looked. And this patient was treated because he has systemic fungal infection. He was treated with amphotericin originally, and then he was switched to voriconazole for 1 year, and then he improved. And blastomycosis is present in the soil. It's present not only in the United States, but we can see it in Africa, and we can see it in some areas of North Africa as well, such as Algeria and Morocco and Libya. Case number 4, we had a 82-year-old male. He's immunocompromised. He has history of multiple myeloma and chemotherapy. He was getting chemotherapy with bortezomib and dexamethasone. And he came in to us because we did a CT scan and we found this nodule. And when you see this nodule in the right upper lobe, you always think about malignancy. This nodule was difficult to obtain from bronchoscopy, so we did a CT-guided fine needle aspiration. And when we did the fine needle aspiration, we see these organisms. And you see a cluster of these small organisms. They are between 2 and 5 micron. And when you see this, you usually, with narrow, sometimes narrow base budding, or without budding, usually the diagnosis is histoplasmosis. And histoplasmosis mostly present in our area here in Ohio, in the Midwest and Eastern United States. It is present in some other areas of the world, such as South America as well. If you have any patient from there, you can see how these are small structures and they stain positive with the GMS stain. The treatment for that, if it's disseminated, you need amphotericin and then itraconazole. If it's not disseminated, you can just do itraconazole for 1 year. Last case I have, this is very interesting case. I had a patient who's 69-year-old. She came with shortness of breath and cough. This patient, interesting, she has severe COVID-19 pneumonia that was last year in August. And after the COVID pneumonia, she was discharged on home oxygen. So she has some degree of post-COVID lung fibrosis. She also has history of renal cell carcinoma and she had a cryoablation surgery. She is also a remote smoker. If you look at her blood work, she had a white count of 23,000, she was high, and high blood glucose, and the rest of the labs were okay. And then we did the chest X-ray and CT chest, and you can see here she had severe lung disease. So you can see some degree of fibrosis on the right lung, which is probably from the sequelae of the COVID infection. And then you can see some in the left lung. There is a lot of cavitation on the left upper lobe, as you can see here. There is pleural thickening and pleural reaction. There is a cavitation, and inside the cavity, you see the structure here. And that's why we did a bronchoscopy and bronchoalveolar lavage from that patient. And when you see this bronchoscopy here, you can see very well that this patient has a lot of membranous structures or nodules of the trachea. We call this feature a pseudomembranous tracheitis. And when you see this, this is very typical of Aspergillus pneumonia. You can see the lavage here was bloody, and we know that Aspergillus love it's angioinvasive, so it invades the blood supply of the lung. And this is the pathology, as you can see very well. This is from the tracheal biopsy. You see these structures. When you see these structures, here you see these, we call them hyphae. When you see these hyphae, you have either Aspergillus or mucormycosis. If the branching of the hyphae is at 45 degree and it's septated, this is Aspergillus. If it's 90 degree and non-septated, then it's mucor. So that the diagnosis was Aspergillus pneumonia, severe Aspergillus pneumonia with cavitation. The treatment for that, of course, you start voriconazole and then you add caspofungin because the disease is very severe. But unfortunately, this patient developed respiratory failure, renal failure, and she didn't survive because of the degree of the illness. And this is the last case. These are the worldwide distribution of these fungi. So histoplasmosis, you see it mostly in the United States and Canada, and you see it also in South America. You can see it also in the whole African areas, and also you see it some areas of the Nepal and all those Southeast Asian areas. Blastomycosis mainly, as I mentioned, mainly in the Eastern United States, but you can see it also in African areas as well. And for our Middle East area, you see it in Libya, Algeria, and Morocco, as you can see here. Coccidomycosis mainly in the United States and South America. Cryptococcus and Cryptococcus, you see it worldwide because it's related to immunosuppression and HIV. So this map showed the fungal distribution in our areas in the Middle East and North Africa. So you can see, for example, in Algeria, there are some cases of invasive candidiasis and aspergillosis, and the rate of those are per 100,000. So you can see it's between 1 to 5 per 100,000. You can see it's either candidiasis, invasive aspergillosis, especially after COVID, we see a lot of invasive aspergillosis, cryptococcal meningitis, pneumocystis meningitis, and mucormycosis. There was a lot of mucormycosis after COVID infection, mainly in India. And with that, I think I am ready for any questions, and I'm happy to be with you, and please let me know if you have any questions. Thank you very much.
Thank you, Dr. Fadi Safi, our friend from USA. صراحة very brilliant lecture. نفتح باب النقاش للأسئلة. سامعني الدكتور فادي؟
سامعك دكتور صابر.
حبيبي الله يحييك. طيب
كيف حالك؟ سامعني؟
والله يسلمك، الله يحييك. تسلم.
يعطيكم العافية.
طبعا دكتور فادي صافي استشاري الأمراض الصدرية والعناية المركزة في توليدو في الولايات المتحدة الأمريكية، وهو بيعطينا محاضرة عن الفنجل انفكشن. في سؤال من الدكتور علاء المصري.
نعم
دكتور فادي سامعني؟ دكتور فادي كيف حالك؟ كيف صحتك؟
أهلا، حياك الله علاء.
صباح الخير. أول شيء عندك في أمريكا.
صباح النور. أهلا.
يمكن صحيناك بدري اليوم إحنا.
لا ولا يهمك، بالعكس.
يعني قبل ما أسأل السؤال تبعي بس بحب أوجه شكر للدكتور فادي لأنه من الأطباء اللي تعاونوا معنا في بروتوكولات مجمع ناصر الطبي، وزودني بمجموعة من البروتوكولات اللي عنده بالعناية المركزة على الإلكترولايتس مانجمنت، هايبو والهايبر كاليميا والدي كي اي، ومشكور جدا. بحب أتشكر لك مرة ثانية دكتور فادي. بس سؤالي دكتور فادي، الفنجل انفكشن هو تقريبا يعني خلينا نحكي البندورا's بوكس اللي احنا مش قادرين نفتحه في قطاع غزة. يعني مشكلة كبيرة لحتى الآن في طرق التشخيص، في الأدوية للأسف مش متوفرة عندنا الأنتي فنجل كلها في قطاع غزة، وكثير من المرضى مست سواء كان في أقسام الباطنة أو في الآي سي يو، وما يعني ما بنصل لمرحلة أن نعطي أنتي فنجل أو حتى نشخصها. إيش أفضل الطرق يعني بتعتمدوا عليها في تشخيص الفنجل انفكشن؟ يعني هل بتكتفوا بس بالجرام ستين والكالتشر، ولا في طرق سيرولوجيكال تيست يعني بتعتمدوا عليها؟ لأنه طرق التشخيص عندنا اعتقد انها قد تكون بدائيه في الفنجل انفكشن. نعتمد اكثر او بنركز اكثر على البكتيريال انفكشن والفيرال انفكشن، لكن بيجيش على بالنا نفكر بالفنجل لانه يمكن الموداليتيز اوف دايجنوزز عندنا ضعيفه في هذا المجال. بدنا يعني زي هند فيما يتعلق بتشخيصها، وايش الاشياء اللي ممكن نعملها عشان نطور طرق تشخيصها عندنا في قطاع غزه.
نعم يعطيك العافية دكتور علاء. نعم صحيح. هلا احنا بدينا نشوف كثير حالات من الالتهابات الفطرية بعد الكوفيد في الرئتين، والدكتور صابر موجود. هلا طبعا انت عشان تشخص افضل طريقه هي انت بحاجه، معظم المرضى بحاجه لبرونكوسكوبي وبرونكيال لافاج وسمتانس بايوبسي، وفي بعض الاحيان ممكن تعمل اللي هي عن طريق الراديولوجي، ياخذ عينه اذا كانت الورم موجود في الجهه الخارجيه من الرئتين. هلا الستينز الموجوده هون انا اللي عرضتها في الباثولوجي، بس انت بدك شخص او خريج باثولوجي او اخصائي باثولوجي يكون عنده خبره في هذه الامراض، هو بده يطلع عليها بشكل يعمل ستيننج. اول شيء بيعملوا شيء اسمه اتش اند اي ستين. الاتش ان اي ستين ممكن تفرجيك انه شو هو الفطر اللي موجود، لكن ممكن تحتاج لستينز اخرى عشان تتاكد ايش هو نوعيه الفطر، لكن ممكن تعطيك اجابه انه نعم في فطر موجود وممكن انه يتعالج هذا الفطر. هلا معظم العلاجات هي دكتور علاء، اول شيء انت الانفوتيرسين بي اللي هو اذا كان سيستميك ديزيز او البيشنت اكيوتلي ال، بعتقد انه متوفر. اذا ما كانش متوفر ممكن انت انه يعني الاشياء اللي اقل فعاليه اللي هو الاتراكونازول او الفوريكونازول. اذا ما كانش متوفر عندك الفلوكونازول، بعتقد انه متوفر اللي هو الدايفلوكا، يعني اللي هو نفس علاج لكن تعطيه بدوز اكبر، تعطيه بدل ما تعطي 400 ملغ تعطي 800 ملغ، وهو نفس الدواء اللي بيستخدموه لعلاج فطريات الجلد او فطريات عند فطريات الاجهزه اليورينري سيستم، يعني في عند الستات او عند الرجال، هو نفس الدواء يستخدم. هلا التقنيات الاخرى اللي هي الاذر ستينز اللي هي جي ام اس ستينز، اذا في عندنا باثولوجي في الغرفه بعتقد ايضا موجوده، لانه هاي برضه يعني موجوده من فتره الثمانينات والسبعينات بيقدروا يسووها. ممكن انه ايضا تفرجيك وجود هذه هي يعني مو يعني اول ما الباثولوجي يتعرف انه في فطر، ممكن الجهه الاخرى هي بس انه الايدنتيفيكيشن، ما بتحتاج بي سي ار لهي الامور، بس على الشكل ممكن زي ما شرحت انا على الحجم، على البادنج، على هاي الشكل ممكن انت تتعرف على هاي الامراض.
دكتور فادي، يعني احنا as working in Gaza not in USA صراحه، يعني احنا عندنا very limited resources. احنا ما عندنا في fungal stain, we don't have fungal stain, we don't have HLE stain. So we have very limited information to approach this fungal infection. As you mentioned, we have faced a lot of patients post-COVID, long-term antibiotic, stay in ICU for 1 month or more. Most of them, they die from septic shock because of fungal candidemia, because of infection. In addition, we don't have the antifungal treatment. Voriconazole, the posaconazole, the caspofungin, we don't have these medication. So we have a big problem facing this fungal infection, and we noticed this in the COVID era. الحمد لله انه الكورونا يعني خلصت ولا كان في مشكله كبيره بالنسبه لهذا بس as you mentioned it's very important topics and need to be يعني بنحطها من توصيات المؤتمر انه وضع identification of fungal infection والcandidemia والfungal stain. By the way, it's very cheap. يعني the fungal stain is very cheap and it is very يعني ممكن تجيبها بأقل ب$10 ممكن تجيب لك أكثر من أي أكثر من stain. بس we have to have a trained staff in our laboratory to identify the fungal infection in order to go directly for treatment, which also we're lacking. We have only amphotericin B, which is, the very catastrophic side effect. Doctor, we have here also Dr. Ala El-Bayouk, our professor in histopathology, and he want to share يعني a comment with us.
أكيد تفضل دكتور.
بسم الله الرحمن الرحيم. We can diagnose fungal infection by hematoxylin and iocine stain only. This is a routine stain can offer in Gaza strip. Last 2 weeks I was able to diagnose a case of fungal infection, mucormycosis in ANT department, and another case by GIT in esophageal candidiasis. We can afford to buy these stains because it's cheap. But if the Minister of Health can supply it, we have only in Gaza KOH stain and glomerular stain and some limited stain. But because of the cases are rare, they cannot supply it routinely. But we can afford